and other community leaders as gatekeepers. They've got influence, so if they are going to be supporting such initiatives, then men will find it easier, there will be less stigma, and will be compelled to support their partners. When you also look at maternal health outcomes, especially early ANC booking, antenatal care booking before 16 weeks, it is one of the indicators which we are tracking as a program. We're also looking at institutional deliveries versus home deliveries. It's also another indicator which we are tracking as a program. We're also looking at the ANC coverage. So that is the main reason why I thought the project or the start will be done in this operational site. The organization, there is a website, those who want to follow it. Pangea Zimbabwe, a local NGO with an annual income of about 4.5 million, with a staff complement of more than 100, with about 6 major projects. So in a nutshell, that's about the project. We're mainly focusing on health, HIV and AIDS, and some bit of research. Is my screen moving?
Yes, your screen is moving.
Okay, thank you. So as you know, Zimbabwe, like many other countries, almost all the countries are members of the United Nations, and we subscribe to the United Nations Sustainable Development Goals, 17 of them. But in this context, we're going to zero in more on SDG 3, on health and well-being, and also partly on SDG 5, on gender equality. Participation of men, active involvement or participation in maternal health programs is slowly gaining momentum and attention, both in Zimbabwe, African region, and also some other parts of the world, where public research has also shown that there is significant improvement in maternal health outcomes where the studies has been done, where men has been actively involved, supporting either with resources, joint decision-making with their partners, encouraging and also accompanying their partners to the antenatal visits, even presence during labor, or even during postnatal visits for various processes that are done during postnatal. And maternal health, we are looking at the physical, the woman's physical, social, and emotional well-being, which covers the time of pregnancy, during childbirth, and also post-delivery. And this is in line with the World Health Organization definition. As you see, Zimbabwe is also not doing very well in terms of the indicators for maternal health. Our maternal mortality rate stands at 363 per 100,000 live births, according to the United Nations Population Fund report. This is versus the international target of 70 per 100,000 lives births. So we can also see that we are not doing well, just like many other African countries. There are various causes that can be alluded to this. We have complications during childbirth that also contributing to maternal mortality rate in Zimbabwe. We also have delays in seeking health care. Some present late at the local health facility. As you know, pregnant women are supposed to register for 16 weeks, especially if it is the first pregnancy, so that there are processes that are done, the screening, various tests, so that any anomalies are detected early before it is too late. But some, they delay to seek antenatal services to register. Some, they don't even go at all. Some will deliver at home due to various reasons, economic, religious, cultural, etc. The other issue is home deliveries. Some are delivering at home where there are complications, where there is no, in terms of cleanliness, there's sepsis, they can be exposed to infection, etc. We also face inadequate medical supplies. That also contributes to the challenges of maternal mortality, where sometimes expecting mothers will be requested to bring their own sundries. Some are also not adequate, and some cannot even afford. The other is also gender-based violence, where as a result of various gender-based violence during pregnancy, that can also contribute to miscarriage, abortion. Some can also contribute to poor health of the mother, which may result in contributing to maternal mortality during labor or just post-delivery. The other is linked to gender inequality, where most of women in Zimbabwe, especially in the rural community, are dependent on men. As a result, some may not have resources to go to the facility. They can delay to report at the health facility, not because they want, but because they might not have resources. Culturally and traditionally, some will also need to seek approval from men to go and register, to go and seek healthcare. All these are some of the factors that contributes to the delay seeking healthcare because of women's dependence on men. Also, shortage of skilled healthcare workers. This is also one of the indicators which we track the proportion of women who have delivered with the supervision of a skilled person. As you know, most rural communities, they may depend on traditional birth attendants, but some may not have been well trained so that they are able to understand issues of infection, issues of sepsis, etc. Where they are trained, I think that's better. The issue of distance to the health facilities. As in Zimbabwe, our primary healthcare model has been good, but as the population was growing, new settlements were being opened. I think some of the communities, they travel more than 50 kilometers. As you know, in line with the Alma Ata Declaration on Primary Healthcare, there should be a healthcare facility within a 10-kilometer radius so that it reduces the burden of walking and traveling to the health facility. But as I have said, post-independence, we had one of the best primary healthcare model. But as the population was growing, new settlements being opened, we couldn't keep pace with opening new health facilities. So this also contributes to maternal mortality, either delayed visit to the facility when they're expecting labor, either even failing to follow up to visits or the required minimum of 4 visits during ANC. All those things, they contribute because of the result of distance. Some may not even have money. We also have bad roads that might be difficult to pass. So all those challenges, especially during rain season, they also contribute to this. And traditionally, maternal health programs have generally focused primarily on women, but however, we have been neglecting the potential positive impact of men, especially the indirect influence in terms of access, in terms of motivation, even in terms of resources. There have also been various researches that looked at the active involvement of men, which have been found to improve maternal health outcomes for both the mothers and the infants. One of them is a study by Moyo et al. 2023, and so many others that has also shown significant impact on the positive side when we involve men actively with their partners in various ways. I've already alluded to the maternal health. The key components of maternal health, we look at prenatal care. That's one of the components. This includes regular checkups to monitor the health of the mother and the fetus. Also, you look at safe delivery services, where we're talking of skilled personnel to provide and monitor women in labor using a pantograph and so many other required guidelines and SOPs. We also talk of postnatal care after delivery. Family planning services, especially postnatal family planning services, are key components of maternal health services. For a woman, it becomes easier after delivery for them to be inserted a loop, for them to have a family planning method, but probably without support and encouragement or cooperation from the male partners, they may end up going home without family planning method. Some, when they return for the 6 weeks postnatal care, some of them will be already pregnant, which will also contribute to maternal mortality because they will not have fully recovered to be able to carry the next pregnancy term. So it becomes important when women will be able to get family planning postnatal so that it gives them enough time to breastfeed, to recover, and also to improve. Nutritional support is another component, and we also have mental health. Maternal mortality ratio, I think, is by definition the number of maternal deaths per 100 live births. It's also an indicator of quality of care for the community, for the country, etc. So these are some of the components of the maternal health outcomes. The antenatal coverage, the utilization of maternal health services, the birth outcomes, maternal morbidity, skilled birth attendance, postpartum care, and family planning uptake. So by involvement of men or active participation of men, definition from Gaio et al. 2021 indicates that when you talk of men's involvement in maternal health, this is when a male partner supports a woman by offering both the emotional support and physical support. It also encompasses joint decision making. This might include when they should have the next baby, how they are going to look after the baby, how they are going to, whatever, all those decisions, they have to be jointly with involvement of woman having a say in that. Another description is, it also refers to being present when maternal healthcare services are being provided. So we've got two dimensions. You can just be giving support from a distance, physical, emotional, participating in joint decision. But the other explanation is to say the male partner will be involved and present during the offering of service, whether they're going for screening, whether they're going for ANC care, whether they're going to receive any treatment, the male partner will accompany and will be present. Whether even during labor, they can also be present. Right, going to the project aim. So the proposed project aim seeks to evaluate whether the active participation of men along their partners in maternal health program campaigns and various activities contributes to improve maternal health outcomes. As I've listed many of the maternal health outcomes, would they improve? Would we have better ANC coverage? Would we have reduction in maternal mortality rate? Would we have less maternal deaths? Whatever, all the various better uptake of family maternal family planning, etc. So either all of those outcomes or some of those outcomes would want to see whether having more women accompanied and having the full support of their partners, male partners, will it improve some or all of those maternal health outcomes? The proposed objectives will be to assess the level of male involvement in maternal health programs in the target site by just looking at the baseline, how many women have been accompanied by their partners when they've been coming for ANC, during labor, and postnatal. So we'll be able to see already where are we standing in terms of baseline, whether we only talk of 13%, whether we're talking of more than 20% or less than 5%. Then that becomes our baseline. And when we initiate now these activities to have men participate actively, then we'll be able to see and compare the difference from the baseline and the improvement in numbers. Then after, we're going to see the outcomes. What were the outcomes before and what will be the outcomes after the initiatives? The other objective is to compare maternal health outcomes between couples where men are actively involved and where those are not involved. So this can also be involved by just looking at the data, but can also be done through interviews with those women who came with their partners and those who didn't have their partners, and whether they have different experience, whether they could say, I think things are better now because I think I feel supported. I felt in the safe hands when I came with my partner, etc. Other objective, we're going to seek to identify the barriers and facilitators to male participation. We also want to see those who would have come and what will be the facilitators, what have enhanced them, what have enabled them to come and support their male partners, so their female partners. And also seek to understand from men, either through focus group discussions, either through interviews, to understand those who might not be able to accompany their partners. What are their fears? What are their concerns? Is it traditional values? Is it culture? Is it lack of money? Is it peer influence? Whatever, we don't know. But we're also going to seek to understand what are the barriers that can limit or prevent those men either willing or that can just make it difficult for them to accompany their partners. And we also seek to provide recommendations for policy, for practice, for implementation, both to our programs that is already involved in primary health care, including maternal health service areas, but we may also go further to have recommendations for the Ministry of Health, either including training of health personnel or just adopting other new ways of doing things. In terms of the proposed methodology, we'll look at mixed method approach, having both components of quantitative and qualitative. The mixed method approach has been proposed because it's going to provide a holistic understanding to the start. It will going to combine the rigor that comes with the quantitative approach, but it's also going to benefit from the depth that is going to come with the qualitative. Answering the why, understanding the numbers in terms of those that are able to participate with their partners or their female partners. Then we'll look at the numbers, but also understand why those that have participated and understand why those who have not participated. So this is going to complement the quantitative rigor and the qualitative depth. The mixed method also allow the start to adapt the start if we have any preliminary findings from the quantitative that can also inform the direction of our interviews and focus group discussions. If we see a pattern, we can now go to dig deeper to understand, does this pattern have any meaning? Whether is it about context, is it about culture, is it about locality, is it about other things? And generally, mixed method will improve the validity of the start through triangulation of these different data collection methods, data analysis methods, etc. Then in terms of proposed data collection, the quantitative component will have surveys where we have structured questionnaires that will be administered to women who would have recently given birth and their partners, both women without partners and those women who came with their partners, and also their partners, to understand their experiences. Then we're also going to look at focus group discussions. That's going to look at men on their own, women on their own, so that they are also able to share, especially we can go to a postnatal clinic and just have a focus group discussion with a group of women who have come for their 6 weeks or whatever subsequent visits for immunization or for whatever follow-up care. We can also conduct focus group discussions with men at their various social networks and platforms to also understand their perspectives. We'll also identify key informant interviews. These are experts who are able to give us more, and they can speak from position of authority. This can include various healthcare providers, obs and gynecologists, midwives, nurses. We can also include community leaders, some policymakers, and also even implementers of other NGOs that are also involved in maternal health, as well as SRH programs. The sampling approach, we're proposing to have a multi-stage sampling technique. This will enable the systematic and comprehensive selection of the diverse and representative sample. So we have different sampling levels depending on what we want to, the sample that we want to get. So this will enable us to ensure that the study is going to have a wide range of contexts and perspectives. It's also going to enhance depth and the breadth of our findings. It will ensure that the study is going to be statistically robust, and also is going to be contextually nuanced, so that we're also going to take note of the various contextual factors, but also adhering to the statistical guidelines and minimum requirements to make sure that we've got a powered sample. The advantage also of having flexibility, where we can also make adjustment at each stage when we are going to be doing the sampling. So the stage 1, we're going to select clinics based on their maternal health indicators. We have more than 18 clinics in this district, and we can look at their profile, and that can also enable us to select the clinics that we want. We're also going to look at the random selecting of the other facilities, so that it also removes an element of bias, where we just put the names of the clinics in a box, or also then we randomly select, so that we're not going to look at clinics that are not performing well, or all that are performing well, or those that are moderate, but we're just going to make sure that we randomly do that. In terms of the couples that are attending, that will be systematic sampling, and also both for the postnatal services. For the healthcare providers, for our key informants, we're going to do purposive sampling, because we're going to look at those with expertise, like the district head of nursing services. We're going to look at either the specialists involved in maternal health, especially obstetrician and gynecologist. Also going to look at other key players relevant to the thematic area. So that's why it's going to be purposive, so that we're going to target where we think we're going to yield better information and what is going to add value to the study. In terms of data analysis, the quantitative component will use SPSS to compare maternal health outcomes between different groups and even different facilities. For the quantitative component, we have interviews and focus group discussions, and this will be transcribed, will be coded, and also use thematic analysis to look at major themes that are coming out and recurring. The presentation will be packaged, graphs, tables, pie charts, etc., depending on the particular audience, but the same study can be presented and summarized in a policy brief, so that you can also target policymakers, and that has to be shortened, and in looking at non-specialist people who are going to be the audience. If it's going to be an article for the journal, it has to be more elaborate and well detailed. If it's going to be an abstract at a conference, it's also going to be a summary, a snippet of what the study would have covered and will be the findings. It can also be a presentation at a stakeholder meeting. We would want to bring the various stakeholders and share our findings so that they can also think of adopting that as a best practice if the findings are going to be convincing. It can also be a dissemination workshop specifically to disseminate these findings to our funders and staff that are involved in the organization. The other way of also disseminating and presenting, it can be a webinar like this, where we can come back again and say that the proposed start, these are the findings, this is the mileage, this is what we covered. Right, so I think in terms of the proposal, this is what we envisage and propose to do. Obviously, we continue to, as a live document, to make adjustment changes, receive feedback, peer-reviewed feedback, and also take cognizance of other contextual factors. But why is this topic even important? So I'm going to delve into this to understand why I think this topic will be of value, both from the global context, from a country context, even to the organization, and even to the individual. Participation of men in maternal services with their partners. There's evidence that have shown element of success. I've cited Moyo et al., I've cited Srivastava et al. 2015 etc. So yes, this being documented in other contexts, we want to see whether it's also going to be relevant and applicable to Zimbabwe, but not only in Zimbabwe, but in the operational area where we are working as an organization. The other aspect that makes this study important and necessary. It speaks to the SDGs, in particular SDG 3 and the target 3.1, which look at reducing maternal mortality rate to about 70 per 100,000 lives. And as I've said already, as Zimbabwe, we're at 363, which means we still have a lot to do. And maybe this start and this proposed intervention may also be one of the game changers among a combination of other interventions to push and reduce our maternal mortality rate from 363 to the global target of 70. So that makes also the study important from a global context as it responds to the SDGs, but also even important to our country context. It also partly speaks to SDG 5, which looks at gender equality and also empowering women. So as men are going to participate equally, giving women a voice, understanding and accompanying them to understand their experiences and their challenges. That can also change the attitude and the dynamics, which can also give and promote gender equality. So this study in that context is also necessary and of value. And generally, maternal health is a critical component of women's collective health and rights. So it also makes the study important. The moral perspective, no woman should die while is giving life. And this is what has been adopted at international level. We have got goodwill ambassadors at high level. The former president of Liberia is one of the icons that have been pushing this, working with UNFPA and other organizations. So that moral perspective for everyone, the country, the communities, the leadership, etc., makes also this study important and valuable to do. Yes, partly it's a cost-effective or even no-cost initiative, but that can go a long way in promoting better maternal health outcomes and reduction in maternal mortality rate. So I think it also makes
Enoch, we can't hear you. Enoch, are you still with us? Enoch, kindly, are you able to continue? We can't hear you in case you're speaking.
I don't know what had happened. Something had happened. I'd been muted. Has it been long?
Yeah, but just proceed.
Okay, can you hear me now?
Yes, we can hear you.
Okay, my apology for that. Okay, so as I'm about to wrap up now, I was looking at the importance of this study from a country perspective. So I've already talked about our high maternal mortality rate. We've talked about developing countries contributing to 99% of maternal deaths, and Zimbabwe were also in that bracket. The socio-cultural dynamics of the target district, it also put this into context. The study will also likely to inform with our local standard operating procedures, our interventions, as well as national policies in terms of improving maternal health outcomes. It aligns with our alignment to the to our targets and commitment to SDG 3, target 3.1. It is also partly linked to the Maputo Plan of Action, which is a commitment our country also made in terms of improving sexual and reproductive health, including maternal health. From an organization perspective, this project will align with one of our projects. This study will align with one of our projects where we're also involved in primary healthcare and looking at improving maternal health outcomes. The results, hopefully, may also improve program effectiveness as we're already involved in primary healthcare. It will also help the organization, Pangea Zimbabwe, to design more culturally appropriate and acceptable health interventions. The studies will also align with our trust of evidence-based practices, where we're going to use evidence to inform our practices, our plans, our proposals, etc. It can also help us to convince traditional and other community leaders in the operational districts, in the target community, and in other communities to promote participation of men in maternal health activities and programs with their partners. I think that brings me to the end of the presentation. My references to support this and any other references not captured. Thank you, and over to you, Edna.
Thank you so much for that presentation. Indeed, this is a very important topic to both the male and female attendants in our audience. And probably just to start us off as we move to the comments and question session, probably now beyond your study, because from one of your objectives you intend to assess the level of male involvement in maternal health programs. But I'm just wondering, how then do we ensure that in as much as you are involving the men in this kind of programs, then how do we ensure that women still maintain their decision-making power and their autonomy over their bodies in this kind of a situation?
Okay, thank you. Yeah, I think that's one of the, it might call it whether ethical or operational dilemma. What we will need to do is to ensure that we communicate this with men through various engagements, so that we point out that participation, even up to the delivery period during postnatal etc., should not take away the autonomy and the decision for women to make in terms of their reproductive and maternal health choices. So yes, that can be a dilemma. It might be the negative part to it, but if that is clearly communicated, I think there should be an opportunity to give space to women to still maintain their autonomy. But while their participation and involvement will also even boost the confidence and the motivation of women. But I agree with you, it might also be the other negative side of it, if not properly managed and handled well.
Okay, thank you for that. And it's a good thing that already you are having considerations on how to counter such. I just move now to the audience to see if we have any questions. Peter has his hand up. Peter, please unmute yourself and proceed.
Sorry, can you hear me?
Loud
yes,
and
Peter,
clear.
we can hear you.
Yeah, thank you very much, Mr. Enock. I really liked your presentation as a future man, a future father, a prospective father. I enjoyed your presentation. Although I don't have, I'm not an expert in this field, but forgive me, I have a lot of questions and you'll bear with me because the topic has been interesting for me. The first one, in your introduction, you talked about that there is significant increase in men's involvement in maternal health. In your work as you have been working, do you know the reason why there is this significant increase in men's involvement in maternal health? That is the first question. And the second one goes to objectives. Objective number 2, where you said to compare maternal health outcomes between couples where men are actively and those where men are not actively. And my question is, how about single mothers? Because they also go to maternal health. And then quickly, when I went to methodology, you talked about survey, focused group discussion, and key informants. I would suggest in the survey, it would be better to combine both men and women. You just make a questionnaire that combines both of them. And then for focus group discussion, this would be very good to include the key informants. And this could also save you more time. And lastly, is about to you are including women who go to clinics, but in my home country and maybe in Zimbabwe and elsewhere, particularly in Africa, I've been seeing women going to places which are not clinics, but they are also escorted by men, their husbands. These are designated unknown women, people who help women to give birth. So will you consider this in your analysis or it is not considered? Thank you.
Okay, that's Peter. Thank you, Peter. Yes, thank you. Thank you for such informative and engaging questions. My response to the first question, it might be a couple of reasons, but I would want to suggest the various advocacy efforts that are being done by different partners in the community might also have changed the patriarchal mentality of the communities.
Unatuma
For
hiyo
example,
ama niambie hao, unajua inafaa iende by 5 ama niwaambie tu watume venye. Okay.
So I think it might also to do with a lot of sensitization, community engagement. For example, our program is also what we call community dialogues, where we also discuss with the traditional and community leaders together with both men and women, discussing challenges to health services, not particularly maternal health only, but across all sectors. So we also get an opportunity to have the women, men interfacing with the community leaders to discuss challenges and issues of men not giving money to women to go to seek services in time. They came out, and there's been encouragement from the traditional leaders to make sure that men should support their partners with resources, etc. So it might be a combination of both. A lot of organizations working on gender equality, giving women a voice, awareness. Things are also slowly changing in terms of the patriarchal depth in the various rural communities. Women are also enlightened, and also maybe the attitude of men are changing. So I would want to say there might be different factors that are contributing, and there might also context-specific factors. Then the comment on single mothers, yes, I appreciate the comment, and honestly, it will be like also a bit on the gender bias. So we welcome the comments, and maybe we'll see how we can also involve. There might be single mothers in terms of actual marriage, but here we're not talking about formally married only. Someone can even still have a partner that can still accompany them, even if they are not formally in a marriage setup. So we can also give room to that. If somebody is accompanied by a fiance or a partner, we can also take that as also a man involvement in one or the other, not even as a husband or a wife, etc. But it's an important point. In terms of survey, I think I've taken note of that. As I also said this during the introduction, I would welcome any feedback so that it will also help to strengthen and improve my proposal. So it can also make sense to combine men and women during survey. And I think I've taken note of that. For the focus group discussions, key informants may come to the focus group discussion, but the assumption is they are well informed, they are well knowledgeable. So probably their participation in focus group discussions may overshadow and dilute the other participants who are not experts. That's my thinking, but I want to be convinced. Then in terms of the other designated facilities where women also go to seek maternal health and delivery services, etc. It is an important point. I've even checked during my introduction that some of the causes of high maternal mortality, it's because people do home deliveries. They also go to these traditional birth attendances, etc., which sometimes they may not have proper procedures for maintaining infection prevention or for maintaining aseptic technique during procedures and a whole lot of other things. So I don't know how best it will be to involve the people who are going to these designated health facilities, but it's an important point. Over to you.
Thank you very much.
Next, we have Alvin. Alvin, feel free to unmute yourself.
Okay, Edna, thank you for giving me the chance to say my cent on this. I want to first of all start by thanking Mr. Enock for thinking about this intervention, this project. and how he has put it. I love the way he has built it, and I may have missed some parts of his presentation because I was juggling between this meeting and another meeting. So, but to me, when we are talking about gender issues or gender equality, I like to look at it from three key areas. I like to look at it from the angle of gender-based violence. I like to look at it from family planning and or contraception, and then sexual and reproductive health rights. There is a way these three play, and then there's a link. They all have a link in actually promoting gender equality. Because sometimes when there are sensitization meetings for women, family planning, on gender-based violence in our communities, most of the times the men don't attend and they feel like it is a women's thing. But at the end, when the woman gets pregnant and the family resources are somehow limited, the man feels that the load is brought to him by the woman. It's like the woman should carry the blame for having more children, more than the family can sustain. So it becomes a problem, but the problem is coming from the angle of men. And what actually makes this even complicated is the fact that women don't have a final say, or a majority of the women, at least, don't have a final say in the decisions of the home. So I will propose that you consider the issues of gender-based violence and having a final say in the decisions of the home, because these two alone can play a lot on men, for example, accompanying their pregnant partners to health facilities. And yeah, so that was just my scent. So we're talking about gender equality. I felt that I could come from this angle because it's an angle I understand. How they play together, the sexual and reproductive health rights, gender-based violence, and family planning. Because sometimes the challenge too, again, is men think that family planning is a women's thing. And when there is pregnancy or there's conception along the line, women are abandoned to their fate, even if the doctors have advised that they don't continue giving birth. But it's difficult for the husbands, for the partners of those women to even understand and believe that what the doctors have said is for the health of the woman and the health of the family, because the woman is very key in the health of the family. So these things, they have the source. If a woman does not have, is not financially empowered to speak on her own, does not have a say in the final decisions of the home, they will play a lot on her getting all the other things that come with gender equality. So that is just what I wanted to chip in. Thank you again, and congratulations for the strong project, Enock. Thank you.
Okay, thank you, Alvin. I appreciate. Just unfortunately, you might have missed some part of the presentation. One of the aspects I talked about was involvement of men would mean joint decision with their partner. So in that context, it might mean, when you look at the definition of family planning, this is about when, with whom, and how, whatever, to have the next pregnancy, etc. It also talks about too soon, too late, too close, etc. So the joint decision can also include when the woman is pregnant, is going to give birth, do they even agree that immediately they can have postnatal family planning, so that when they go for 6 weeks, they might not even be pregnant again, which doesn't give the woman an opportunity to recover properly and also breastfeed accordingly, etc. And also, I like your context of looking at GBV, family planning, and SRH, all having a play in terms of gender-based violence and gender equality. Thank you.
Thank you so much for that. I'd like to invite Emily for her comment.
Thank you, Enock, for the opportunity, and thank you, Enock, for the presentation. I think it's time we focus on such conversations for the benefits that they have on women, and I'd like to echo what Alvin has said concerning maternal health and the various factors concerned that ought to be considered to ensure that the maternal health of women are improved, and also to echo the imperative that you mentioned on that no woman should die while giving birth. Being a woman myself, this is something I support, and this is something that is I've seen some women undergo, mainly because of situations that could be avoided, and which is not a good thing. So from the presentation, Enock, we've seen that in Zimbabwe, the rate of maternal mortality ratio is too high. It's actually 5 times above the level recommended by WHO. And knowing that men have a key role to play in ensuring the maternal health of women is very important. It's only that we didn't get to see the results, which I think you still are in the process. And I believe from your result, I would like to know at the end of the study, maybe I hope you'll be given a chance to present the findings so that we may ascertain with certainty that, or even pinpoint the factors that enhance the well-being of women because of having been accompanied or supported by men. And on that front too, I hope from your study, you will come up with recommendations that maybe might inform our policies so that the policies can encourage men to support their women while pregnant, even if it means men getting a day off every month to ensure that they support or they accompany their women to the clinics during the monthly clinics will be key based on the findings that you'll generate from your study. So thank you for this. And I think going forward, we need to have such conversations because, you know, most of our African men they have the fixed mentality and might shy away from accompanying their pregnant women to clinics. But I think this is a good step, especially if it will guarantee that the rate of maternal mortality is reduced to the recommended levels. Thank you.
Okay, thank you, Emily. I appreciate the feedback and the comments. And definitely recommendations, I'm sure, should also include even giving incentives for women who are going to go with their partners, etc. But we know on the other angle, some might want, but probably may not have the convincing power to bring their partners. But I appreciate the feedback, and I think it's going to be interesting, and we'll be able to stay in touch.
Okay, that's well noted. Next, I'd like to invite Florence for her comment, then Lavender.
Thank you very much, Edna. Thank you very much, Enock, for this relevant discussion. I believe there's immense potential to expand the concept of male involvement beyond just pregnancy and childbirth. Firstly, including men in broader family planning initiatives, like a presenter, as a participant has just mentioned, could be very beneficial, because traditionally, family planning discussions often revolve around the woman. But when we involve men in these discussions, it could foster that sense of shared responsibility and encourage more informed decisions around contraception. And this could lead to unintended pregnancies and contribute to better maternal health outcomes for all. Secondly, I think men can play a crucial role as advocates for improved maternal health services within their communities. They can be powerful voices, just challenging traditional norms and promoting the importance of seeking prenatal health care, and even seeking skilled birth attendants and postpartum support. just imagine men encouraging other men to prioritize their partner's health and well-being, or even accompanying them to health facilities. This could significantly improve access to care and shift social attitudes towards maternal health. I believe that by expanding male involvement beyond the immediate stages of pregnancy and childbirth, we can create a more supportive environment for women throughout their reproductive journey. That is what I have to say. Thank you.
Okay, thank you, Florence. Yeah, I agree. It might not just be about maternal health, it will even encompass other social systems, etc. This might just focus on the maternal health, etc. But I think this application can extend to other 360-degree aspects that revolve around a family. And I agree with that.
Lavender, please proceed.
Thank you, Edna, for that opportunity. Can you hear me?
Yes, we can hear you.
Yes, loud and clear.
Right. Thanks, Edna. Thanks, Enoch, for that wonderful presentation as well. I think this is a critical topic that we really need to look into deeply, and the aspect of improving this health, looking at the benefits. I think it's such an amazing idea that as researchers and even policymakers and even technocrats, we need to look into and come up with feasible solutions that can be used to improve the health of the nation, or rather the continent as well. So I have a question. Looking at the aims and the objectives of this study, I feel there's something that's kind of missing, like a gap. And this is kind of tied to the current in the context of the maternal health care. Ideally, we know like women are given a certain grace period. I think it's like 52 weeks for their maternal, is it holiday or leave, sort of, and men is something like 20 days. I don't know, it's something few days, that is. Do you think this can to some extent pose the negative impact that we're seeing as improving, that limit the impact of male engagement in the healthcare program?
Yeah, I think it might have a contribution. And as we say, 20 days, in some organizations and countries, there are no even days for that leave, even 0 days. So I think it might have a bearing that probably for the limited number of days, and usually, if I'm not mistaken, the days that are given to men is usually only after a delivery, not before. So I think this might also be a hindrance in terms of, especially when when you look at working men. So I'm sure that might also have a contribution. That might also vary from country to country, and also even organization to organization in terms of their labor policies, etc.
Yeah, because I feel like it should be included just to determine the level of the national or even the local healthcare policies and how they support or they hinder this male involvement in the maternal health programs, and also what changes are needed to be done to enhance the male participation. Yeah, so thank you so much for that presentation. That was a well elaborated one, and we're looking forward to the result and even having you to present next to let us know what you got and what should be done, and even as the policymakers, what we really need to put on the table during those high-end policy roundtables. Thank you, back to you, Edna.
Thank you so much,
Okay.
Lavender and Enoch. At this point,
Thank you. I hope Arin will give me some funding, as I'm still looking for funding. Thank you. I would like also to take the opportunity to thank you for also giving me an opportunity to share with you. You know, it's an exchange. I also learn from you, from others. We cross-pollinate ideas otherwise. Thank you so much.
That is well noted, Enoch. I'd like to call upon Dr. Gezi for his remarks.
Thank you, Edna, for giving me this opportunity, at least, to comment on today's presentation. I would really want to appreciate Mr. Enock, Pangea, program manager, for this elaborate presentation. And indeed, it has been a very nice presentation. And it is actually a paradigm shift. It is going to be a paradigm shift whereby we are going to appreciate that as men, that our role doesn't just stop there, but we need to be supportive of women until that stage when maybe children maybe are born, among other things. And actually such fora are good for us, because you have been able to present your proposal, and from it we have been able to learn. And I know also you have been able to learn, because in such fora what we encourage is, we do encourage what we call peer-to-peer learning. And I believe that you are going to enhance the proposal further, so that then as you look for partnership, and you look for even areas where you can maybe submit, I believe you'll be able to get the funding that will enable you actually undertake this research. And as the previous presenters have said, that we are looking forward to actually reading some or looking at the findings you will get. And I know from the findings, you will be able to actually recommend a way forward in which we can be able to maybe enhance further the maternal health program, and not only the maternal health program, but the entire health system. And I believe this particular work can be even, we can replicate this work. Once we get the findings from this, we can replicate this work to other countries, so that we as a continent try to address these SDGs, and together we ensure that we reduce these maternal mortality that are still high within our continent. And as Irene, I believe that we are going to have a conference on climate change and health. And I believe by then we shall have findings from this work, which maybe we will be able to showcase, so that we are able to listen to it, and also the entire world is able to listen to it, so that we can be able to make informed decisions. So I appreciate a lot, Enock, and let's keep interacting, so that we are able to make our earth a safe place for everybody. Thank you very much.
Thank you so much, Dr. Gezi, for that. Enock, do you have any response to that?
Okay, thank you. I don't have much to say, just to appreciate the platform provided by Arin, the good work that we are doing to promote peer learning. We learn from each other across country boundaries, different contexts, etc. And I hope to continue interacting with you and other members of the network, continue to get feedback as I polish and refine my proposal. And definitely we'll continue to be networking and collaborating together in terms of exchanging information. And I also bring in members from the Zimbabwean community to also be part of this network, as it's a collaborating and learning platform that is going to be mutually beneficial for both countries and also for individual researchers and practitioners. Otherwise, thank you.
You're very much welcomed. We've reached the end of this session, so I'd like to ask Enock to stop sharing so that we can have our final group photo before we close. That's right. For those who are in the call, could you kindly turn on your cameras so that we can have our final photo? You could probably smile. Thank you so much for that. Yeah, that's very good. Thank you all for attending this session. And of course, keep interacting with the Africa Research and Impact Network across our social media platforms and also on our website to learn more and to get some of this content. Thank you so much. Have a blessed weekend.
Thank you. Bye.
Bye.
Thank you. Bye.
Thank you.